Good morning. I, as acting chair Dan Hartong, call the prescription drug affordability meeting of February 18th, 2026 to order at 8:04 a.m. Melissa, can we please take roll?
Chair, excuse me, Chair Shelley Bailey is excused. Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman.
Present.
And John Murray is excused. We have a quorum.
Terrific. Well, we welcome everybody to today's meeting. As you see, Chair Shelley Bailey is unable to attend, and so I will be serving as acting chair today. We have American Sign Language interpreters with us, so you can please use the Zoom controls as shown in this slide to access the interpretation channel. So hopefully that's straightforward. Okay. As usual, our agenda begins with conflict of interest declarations, which are stated each month according to board policies. Do any board members have any declarations of potential or actual conflicts of interest? Or have any board members met with entities or individuals related to board activities? Or have any board members provided testimony to the Oregon legislature about prescription drugs? Okay, seeing that we have no declarations, we'll move on to the next agenda item. Actually, the next is approval of the January 21st minutes. Do board members have any corrections to the draft minutes from January 21st, 2026? Hearing that there are no corrections, the minutes are approved as presented. And the next agenda item is a PDAB program update from our executive director, Sarah Young. So I will pass the baton to Sarah for our program update.
Thank you, Vice Chair Hartung. Good morning, members of the board. In January and February, the PDAB team has been focusing on developing and releasing the interactive dashboard to provide more options for viewing the 2026 preliminary drug and insulin lists and exploring the available data. I want to extend a special thank you to Vice Chair Hartung for providing advice to our team on useful data visualizations to include in that dashboard. We have reached out to nearly 700 contacts in the clinical, patient, consumer advocacy, and prescription drug communities to share information about the community forums that are planned for April and May. If folks attending today's meeting have contacts with Oregon patients and consumers, please help us spread the word. All of the dates and times for these upcoming forums, both in-person and virtual, are listed on our website at dfr.oregon.gov/PDAB. And please let us know if you have any questions or any accessibility needs to participate in a forum. And the flyers in both English and Spanish are also attached to today's agenda packet. So again, please share those widely with anyone who may be interested. The team had also worked on drafting the 2025 Drug Review Report, which we will be discussing with the board today. Thank you for the guidance that board members have provided during the last couple of meetings regarding policy recommendations that you want to consider for inclusion in the drug review report. At the same time, the drug price transparency team has focused on releasing the reporting templates and instructions for reports from insurance carriers and pharmacy benefit managers. These reports, which are due annually in May and June, will provide updated information about prescription drug spending and market operations in calendar year 2025. And again, that's part of the annual Oregon Drug Price Transparency Reporting Program. DCBS also issued a temporary rule last Friday reinstating the annual price increase reports for pharmaceutical manufacturers. The DPT team has sent a notice and instructions to registered manufacturers to complete their required reporting. For this year only, the DPT program extended that reporting deadline to April 15th. It's usually March 15th because of the delay in getting the new guidance out. And as a reminder, those reports were paused for a couple of years due to an active litigation. Next, I wanted to share a few legislative updates. As folks know, the current short session of the Oregon legislature started on February 2nd, and there are several proposed bills that may be of interest to PDAB members, so I wanted to flag them for awareness. For one, the amendment to Senate Bill 1528 would expand Oregon's current requirements for patient assistance program reporting from drug manufacturers. The proposed language that's currently in the amended version of Senate Bill 1528 would apply to all manufacturer-funded patient assistance programs offered in Oregon and require annual reporting on those programs. The Senate Health Committee passed that amendment on Monday and recommended passage of the bill. And some of you may be aware, our DFR's policy director, Jesse O'Brien, and I spoke to the Senate Health Committee on February 2nd about considerations around patient assistance program reporting. Also, House Bill 4040, which we will spend a little more time discussing in today's meeting, includes an amendment changing part of PDAB operations. That is just one of many healthcare items in that large omnibus bill, but we want to be sure to give the board a chance to talk about that proposal. Also, I wanted to say that I really appreciated feedback from Chair Bailey and the team about how we can feasibly keep PDAB members informed during the fast-moving legislative session. And I apologize that we didn't get information out as quickly as I would have liked in retrospect for this session. So going forward, my plan is to work with the team to notify board members about any proposed bills or amendments that would modify the PDAB statute. And really the goal here is to share email updates as promptly as possible after bills or amendments are posted to OLIS, which is the Oregon Legislative Information System. I do want to, level set, given the volume of legislative activity, we will really only be able to focus on updates to bills and amendments that directly reference PDAB's authorizing statute, which are ORS 646A, 693 through 697. Unfortunately, it's really not feasible for our small team to track the many other healthcare related proposals that could occur during a legislative session and provide updates to the board about those. And just also, again, due to the volume of information, we can't realistically commit to providing updates about committee hearings or work sessions or other legislative activities. We do want to do what we can to flag information that may be of interest to the board members during sessions. So Board members, please let me know if this proposed approach would be helpful to you. And I realize the short session, wow, that's a tongue twister, will be ending in early March. So we probably don't have much more chance to put this into effect for this year, but this also gives us a chance to work out our process to be ready for the 2027 long session next year. And with that, Vice Chair Hartung, I will turn it back to you. Thank you for your time.
Great. Thank you for that update. And I know we have another discussion item on House Bill 4040 on our agenda for later in the meeting today. So look forward to that discussion. The next part of our meeting is related to public comment. And the board received 11 written comments, which are posted to our website. And the board also received 6 requests to speak. The 11 written comments are from, and I'll just read the list. There are letters from Michael Peters from the Global Coalition on Aging, Daria McGrew from Pharma, Mary Watcher from Genentech, Leo de Guzman, Sam Miller from the National Infusion Center Association and Infusion Access Foundation, Dr. Harry Gawanter from Let My Doctors Decide Action Network, Carissa Kemp from Sanofi, Melody Calkins from Bio, and Lisa Bozinovich from Oregon Life Sciences, Cynthia Ransom from Lilly, Mary Ann Cooper from Regents Blue Cross Blue Shield of Oregon, and Tiffany Weistrich Robertson and Vanessa Lantham from Each Pick Coalition. So those are the 11 letters. And again, we received 6 requests to speak at our meeting. So I'm going to go through individually and call the individuals who requested to speak by name and their organization. They will have 3 minutes to speak on their issue, but the board will not deliberate on issues or requests during this time. So the first individual who has requested to speak is Daria McGrew from Pharma. So hopefully we can find her and provide her 3 minutes. Okay.
Hi.
Hello.
Good morning, Acting Chair, board members. Thank you, Daria McGrew, on behalf of Pharma. A couple of things. I'd like to highlight our letter that is on the record for this month is in response. So February 9th letter is in response to the January meeting. I want to express serious concerns about the process used to select one insulin product as potentially unaffordable. None of the insulin products initially received enough votes, but board members were instructed to reconsider and focus on a single product, subsequently changing votes. This happened without a clear process or discussion about the class as a whole, and board members were only reevaluated one product. This is another example of how the statute's requirements lead to arbitrary board decisions. Despite proposed legislative fixes for similar issues in previous years, ongoing flaws in data and procedures remain. Secondly, we're deeply concerned about the board's recent shift in approach to affordability reviews for orphan drug products. The statute states the board cannot review a drug designated as an orphan product. It does not address reviewing specific indications. That interpretation is inconsistent with the clear language of the statute. Additionally, though, and perhaps more importantly, I want to raise significant practical challenges with this approach. The board cannot consistently separate data based on how the drug is used, since pharmacy claims do not reveal the reason a medication was prescribed. This is according to the APAC manual. There are not diagnosis codes included in the APAC data. As a result, if the board decides to review drugs simply based on whether the data happens to be easier to sort, for example, pediatric indications, this approach would not fairly treat all drugs in the same way and poses a risk for another arbitrary decision, unfortunately. Following the meeting today, we will send a letter detailing a few issues identified in this month's meeting materials, but I want to just highlight quickly before you set off on the meeting. The revision to the board policy indicating it has determined to categorically decline volunteered confidential information. While we recognize that the current open meetings law does not safeguard this information from media exposure, we do recommend pursuing legislative amendments to protect voluntarily submitted confidential, proprietary, and trade secret information moving forward. I also am concerned about the language in the mini reports proposed on certain drug products. These reports place a lot of emphasis on WAC price, which, as you know, does not accurately reflect the cost to the healthcare system or to patients. Similarly, your proposal to discuss some type of state-level inflation penalty would again focus only on WAC without regard for the many other factors that go into affordability and has serious constitutional legal flaws. Again, due to the short nature of the comment period in Oregon, we will submit a letter detailing these concerns after this meeting. Thank you.
Great, thank you. The next person on my list here is Primo Castro from Bio.
Acting Chair, members of the board, Primo Castro with the Biotechnology Innovation Organization, known as Bio, and appreciate the opportunity to provide comments today. Joint written comments were also submitted ahead of this meeting. At the January meeting, the board presented it on its perceived authority to review drugs with orphan drug designations. In this discussion, several board members made remarks claiming that it would be time-consuming and difficult to remove orphan indication data. Members went on to deliberate whether drugs with multiple orphan indications should be removed from the preliminary list or whether the board should only remove drugs with a single orphan indication. Bio strongly believes that orphan drugs, including those with multiple orphan indications, should not be subject to the drug review process given the importance of the orphan drug exception and the need to maximize protection for rare disease drugs. While each rare disease affects only a relatively small number of patients, collectively, over 30 million Americans are affected by a rare disease. The federal government has an extensive existing policy structure intended to support innovation and investment in orphan drugs and conditions for which patients are desperately waiting for cures and treatments. The Oregon PDAB cannot risk undermining the important incentives provided at the federal level to support rare disease innovation. Thank you.
Great, thank you. The next person on my list is John Mullen from the Oregon Coalition for Affordable Prescriptions. I see you, John.
Yes. Okay, I'm ready to testify if you can hear me okay.
Yes, we can. Thank you.
Okay. I'm John Mullen, members of the board, president of the board of the Oregon Coalition for Affordable Prescriptions, also known as OCAP. I want to start out by saying that our grant cycle with Arnold Ventures has come to a conclusion. The future of OCAP is uncertain at this point in time, but I want to begin by thanking all of you, members of the board, thanking the staff. I also want to thank our own board and our contract providers who have worked diligently on this issue. I want to also add a really sort of a personal note for me. I have testified before in the past to acknowledge that I am no expert on prescription drugs. I just passed my 3/4 of a century birthday back in November, and I'm fortunate not to need ongoing prescription drug for any condition that I have. I feel very fortunate about that. Why I got into this, in my 50 years of human service work, noting that there were equity and affordability issues for many things, but prescription drugs being one that I went ahead when I was director of Clackamas County Social Services, set up a small nonprofit with my own money where we could pay for emergency needs for clients. Among those were prescription drugs, where we had agreement with a couple of local pharmacies and we had a voucher system, and it was all something that worked to the benefit of the people who are in an emergency, but also had safeguards about making sure that we were providing what was actually necessary. So we did that for a number of years, and we could only help a limited number of people. Felt like putting a hand in the dike and not getting very far along with it. But we did help some individuals with that. And so my issues basically have been not in the area of expertise that you all hold, but rather in the matter of equity and affordability. And I just also want to recognize that the work that you are all doing as a board is very difficult. But we have a fine tradition in Oregon about taking on difficult things. I was involved in the early days of the Oregon Health Plan, the change of the long-term care system. These things were difficult, but there was creativity that was put to it, which is part of the hallmark for Oregon. So in what may be my parting comments to the board, I wish you all the best, and to hold up that high standard of Oregon, doing difficult things with creativity that benefit Oregonians. Thank you very much.
Thank you, Mr. Mullen. Appreciate the comments. The next person on my list here is Mary Ann Cooper from Regents Blue Cross Blue Shield of Oregon.
And Acting Chair Hartung, I did switch Mary Ann's settings. Let's,
Okay.
oh, actually, let me try this again. Well, okay, Mary Ann.
Now I'm
I think-
good. Sorry. Yeah, I was like
Yes.
frantically hitting it and it wasn't working. Was my audio good?
Yes, we can hear you.
Thank you. Chair Hartung and members of the board, my name is Mary Ann Cooper and I am the Director of Government Affairs for Regents Blue Cross Blue Shield of Oregon. On behalf of Regents and the nearly 1 million Oregonians we serve, thank you for the opportunity to comment. We share the board's commitment to improving prescription drug affordability. We understand the board will no longer pursue upper payment limits for the drugs under review. However, we are concerned that the policy recommendations discussed in January will not meaningfully improve affordability for patients using these medications. These broad system-wide proposals risk unintended consequences, duplicate federal efforts, and may increase premiums without delivering timely relief. The board's review process identified specific drugs requiring immediate action, yet the proposed recommendations extend far beyond those drugs. Broad reform may serve other policy goals, but they do not constitute a targeted response to the affordability challenges identified through this review. Most of the proposed policies fail to include analysis demonstrating how they will reduce out-of-pocket costs for patients using these 4 drugs. Without clear impact analyses, the proposals amount to policy experiments while patients continue to struggle. Potential consequences include access disruptions, cost shifting that raise premiums, and new administrative burdens. For example, delinking PBM payments. Delinking is largely theoretical and risks undermining PBM's ability to negotiate discounts and rebates. Removing this tool could increase costs for drugs under review. Eliminating specialty tiers. Specialty tiers help promote a use of clinically appropriate, better value medications. Prohibiting them would reduce competition and increase drug spending, raising premiums. Formulary stability with no mid-year changes. While stability is important, eliminating all mid-year changes would prevent plans from responding to new generics, biosimilars, or new clinical evidence, all of which would increase costs. Targeted out-of-pocket caps. Cost-sharing caps may help some individual patients, but do not address underlying drug prices. These policies shift costs elsewhere while allowing unsustainable pricing to continue. We urge the board to focus on drug-specific, evidence-based interventions. Healthcare financing is complex, and broad reforms based on incomplete understanding risks destabilizing the system and increasing costs. Collaboration with plans, PBMs, manufacturers, and providers, and clear actuarial impact assessments are essential to deliver meaningful affordability improvements. I have more detailed comments online, but appreciate your consideration. And we look forward to finding ways to work together collaboratively to improve prescription drug affordability for Oregonians. Thank you.
Great. Thank you, Ms. Cooper. The next person on my list is Lauren Sand from Caring Ambassadors Program.
Good morning, everybody. Thank you very much for having me here today. For the record, my name is Lauren Sant. I'm the Executive Director of the Caring Ambassadors Program. And I really appreciate that you're reaching out again to the community for these meetings and that you're trying to dedicate some time to patient engagement. It's greatly appreciated. And we have already started to distribute the flyer. However, I really hope that you plan to change the presentation from the last meeting. I attended 2 of the in-person meetings and they were confusing and quite frankly, a little disheartening. The presentation had a slide about the entire supply chain, but we were told that it was too confusing and that it was like looking at the back of a TV and you really shouldn't pay attention to it. And they immediately slipped into, this is why we need UPLs. No discussion whatsoever about why and the what fors. So I'm concerned that the meeting might be the same ways unless you really change it up. And it starts with, my concern started when your flyer came out and it said, learn why drug costs are so high. This is not the right question. The goal of the meeting should be to learn from patients, not for patients to learn from PDAB. The Caring Ambassadors has proudly been a part of the Each Pick Coalition in an effort to learn directly from patients on how experiences healthcare and affordability. And our recent survey simply, instead of yes, no, the tool used qualitative, quantitative data and really looked at patient narratives. And it allowed respondents to explain how insurance design, cumulative healthcare costs, and life circumstances affect their access to care. And the data said 95% of patient responders who stopped treatment for cost reasons cited insurance-related challenges. So I hope that you will use these meetings to really consider and listen to the patients, not tell the patients. And I will spread the word. I will help as much as I can. I know patient engagement is really hard. It's hard to get patients there. Hopefully with these times that you have, they're more patient friendly than sitting through a meeting on Wednesday from 8 to 4 or 8 to noon. So just word of the wise, like work with us. We can help you. We can help you design some of these questions so that maybe patients come prepared. And the Each Pick Coalition is here for you. We're a group of patient advocates from around the country, and we'd really like to help. So that's all I have to say. You got a tough job ahead of you. Thank you for all you're doing, and I hope we can work together and make the change Oregons need. Thanks.
Great. Thank you, Ms. Sand. The final person on my list is Charlie Fisher from Osprey.
Good morning. My name is Charlie Fisher. I'm the state director at OSPIRG, the Oregon State Public Interest Research Group. We're a statewide public interest organization representing thousands of members across Oregon. And I just want to say up front, we don't take any corporate or business money. We're completely independent and are primarily funded by small contributions from regular Oregonians across the state. And as you might imagine, we hear all the time from many of those people who are directly affected by the high cost of prescription drugs. And it's no surprise that cost has caused about a third of people across the country to change their behavior when it comes to their prescribed medication, either by skipping doses or simply not filling a prescription at all. And so in light of that, the first thing I wanted to say was just congratulations and thank you for the work that you have been doing, specifically completing your first affordability review last month. That's a big step in the right direction. And I know was the culmination of years of hard work done by members of the board. I want to provide some feedback or thoughts on what you should think about when looking forward to the next drug review. So, most fundamentally, we believe the board should prioritize analyzing the drugs that have the highest cost for the most people. And it's really important to remember that in addition to just out-of-pocket costs consumers have to pay for specific high-cost drugs, we all pay the price for these high-cost drugs through higher premiums, as well as higher taxes, or reduced government services, or likely both, when government has to pay for these high-cost drugs. So it's really important to remember that this affects all of us, not just although probably most significantly, people who are actually having to pay for these high cost drugs. So when you're thinking about which drugs to review this year, I think that we would recommend that the first place you look is the list of drugs that are a part of the Medicare price negotiation program. As you know, Medicare recently started negotiating the price of some drugs. As a result, Medicare began paying less for 10 of the most expensive and popular drugs, which will save about $6 billion in taxpayer money nationally. If a drug is too expensive for the federal government, it's probably too expensive for Oregonians. And I think really importantly, only 22% of Oregonians are covered by Medicare. So that means a significant majority of the state are not benefiting from this program that is being done by the federal government. And additionally, since the federal government has already kind of done the work of negotiating that price, the process of determining an upper payment limit, which we hope Oregon's PDAB will have the authority to do in the future, will be made much easier. Colorado's PDAB, the first in the country to set a UPL, did so for Enbrel at an amount.
I think we're out of time.
Okay,
Mr. Fisher, apologize.
I just have like 2 sentences left, if I can just quickly finish.
Sure.
So Colorado's PDAB, the first in the country to set a UPL, did so for Enbrel at an amount that was specifically based on the Medicare negotiated rate for that drug. It's estimated that Colorado's UPL has the potential to save up to $32 million from drug spending. So again, we just urge you to prioritize drugs under the Medicare price negotiation program, and I think really would support your perspective on orphan drugs and looking at the non-orphan designation. Okay. 6 of the top 10 selling drugs have orphan designation, so that's really important.
All right.
So thank you so much.
Okay, thank you. Okay. Those are all the individuals that are on my list and who requested to speak. So now we'll be moving to the next agenda item, which is an executive session. So the board will now adjourn to executive session for legal advice pursuant to ORS 192.662F. Representatives of the news media and designated staff shall be allowed to attend the executive session. Representatives of the media are directed not to report on or otherwise disclose anything said during the executive session. All other members of the public may not attend. The public may stay here in the Zoom room. The board will return to open session in approximately 30 minutes. No decisions will be made in the executive session. And at the end of the executive session, the board will return to open session and welcome the public back. So we are starting now. Okay, so the executive session is ended and the board has returned to open session. So Melissa, I think we need to just recall the row to make sure everyone is here, including myself.
Yes, Chair Shelley Bailey is excused. Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman.
Present.
John Murray is excused, and we have a quorum.
Okay, great. Each year the board reviews its policies and discusses any needed updates. There's only one of the board's 4 policies needing a revision today. As background, in August, the board received a public comment letter from a pharmaceutical manufacturer. The manufacturer stated the letter included confidential information. The manufacturer later redacted the confidential information and staff passed on the redacted letter to board members and posted to the board website. Board members discussed the situation at the September board meeting and concluded that they did not wish to receive confidential information. So staff and DOJ counsel revised the board's policy. The State Archives Office reviewed the proposed policy to ensure it meets state records retention laws. And I will call on Courtney Whitlock to begin our discussion of this policy change.
Thank you, Vice Chair Dr. Hartung. Let me get my screen sharing. And thank you for providing the background to the language that we're primarily going to focus on, but I did want to point out there has been additional updates to the policy just to be in alignment with statutory changes. If the board recalls, we submitted statute cleanup last year that became effective in January of this year, which removes the generic drug report from being submitted annually mid-year and have that incorporated into the end of year report. So the language for that has been updated in this policy just for clarification. So again, ensuring that this generic market information will be in the annual report submitted. Instead of having 2 reports, it's now 1 report. Just an additional little clearing up, ensuring consistency of where OARs truly belong and clarifying specific language to be non-gender specific. So this is and I apologize that this is kind of split with the trade secret information under the section 7. But basically adding a new section of information regarding kind of the actions board will take when receiving trade secret information. I did want to take a moment to point out a word here, except would best be removed due to we will be accepting this through normal process. It can be accepted by staff and then reviewed through the process, but it would not be presented to board members and then would be deleted. So I just want to clarify if there's, part of the conversation now is to have this word here removed to ensure the intention is maintaining or the removal of the word maintains the intention that we will accept it, but then it still creates the clarification that it will not be reviewed or retained. So do I have kind of an initial agreement that this word can be removed before we start voting on the policy update? This is shake of the heads is all I need. If there's a concern with that, please speak now. Otherwise, I'm going to check change on and leave that off. Board members, for this section, is there any questions, comments, or additional edits that you see needs to be done to this added language? Hearing none. Just a quick scroll again, just ensuring language is consistent throughout the policy. We did remove here again that the board will not meet in executive session to discuss trade secrets. That's an alignment with the current additional added language above. And then down here, just clarifying that it would just be state email accounts and information. Any questions should go to the executive director, who's ever the acting executive director, removing the former executive director's name. And again, just policy cleanup. All right, board, is there any questions, comments, concerns about the changes to the policy number 1 for this year's review?
No.
All right, hearing none, seeing none. Oh, Michelle, yes.
Courtney, can I just state for the record the reason for the removal of the deliberation on trade secrets in executive session is due to the ability for media to be present?
Yes, that's a, yeah, thank you for that clarification. All right. I guess if there's no additional conversation, we need to vote. So Melissa, do you have motion language by chance?
I do not have motion language. It would be to approve
Yeah.
approval
So
of the policy.
if I can ask for a motion and then a second from the board, I appreciate it. Dan, you want to give it a
Sure. I would move that we accept the revisions to our policy as written. Or as amended, I guess. Yeah.
Sounds good.
I'll
Is there a
second.
second? Michelle, was that you?
Yeah.
Okay, thank you. We have a motion and a second. Melissa, will you please call roll?
Lori Hoagland,
Yes.
Dan Kennedy,
Yes.
Michelle Coder,
Yes.
Chris Lehman,
Yes.
Acting Chair Dan Hartung.
Yes.
Motion passes.
Okay.
All right, thank you. Back to you,
Great.
Dan.
Thanks, Courtney. And actually, I think we're going to go to you next. So I will call on Courtney again to discuss the next agenda item, which is a discussion of House Bill 4040, and as it relates to PDAB activities.
All right, thank you, board. I need just a moment to share my screen. Okay, I'm having some technical difficulties with this one. Give me just a second. Right. Board, are you able to see my screen?
Yes.
Yes. All right. Thank you. So this year's session included language regarding or a section within this bill that it could impact or could have impacted the board. And I apologize, I am having some technical difficulties. I think I'm in the same boat as Dr. Hartung with, there you go, see what's going on here. So basically the overview of House Bill 4040 2026 is a very broad healthcare reform bill that included multiple healthcare divisions and perspectives to improve for the short session. There's one section that pertains specifically to the board, which was sections 38 through 39. And the language intended to have the governor's office select the chairperson for PDAB. Under our current regulation under the ORS 646A.693, it does state that PDAB members elect their chairperson. As you can see, the slides were updated from when the packet was originally posted. So in red, I did update that language was removed back on February 12th. So, and that was the only PDAB governance change within the bill at the time. However, during that February committee meeting, there was an amendment -14 that suggested updates to the statutory language to identify that the board may identify at least one insulin product from the list provided along with the identified up to 9, and that language was adapted into the House bill. So it is now under section 35 in that House bill. And what this will do is just change the language that each calendar year the board shall identify up to 9 drugs. And then you may identify at least one insulin product from the list that are provided. So that was the most significant change and the only impact. So this kind of alleviates the concerns that you heard kind of during public testimony and have received to needing to have to identify one to if an insulin product is determined not to meet the statutory criteria, then it does not need to be selected. So that is the highlight. Do any of the board members have any questions or anything about the updates that have applied under House Bill 4040 2026? All right, hearing none, Vice Chair Dan, I will send it back to you.
Yeah, so sounds like, I mean, we can still discuss this if we want during this time period. But it sounds like there may have been concerns in terms of notification of PDAB board members about potential PDAB related changes. And it sounds like from our executive director that there's going to be a more tight process for identifying those changes during these short sessions where time is, there's short fuse on these things. And so I'm happy to hear that a process now is in place to let board members know about, potential changes to the governance structure of the board. And I don't have any specific concerns, but I'm happy to, if other board members want to discuss that as well during this period. Board member Lori Hoagland.
So this bill is in the Ways and Means Committee, as I understand it. And these changes will depend on whether this bill as a collective omnibus bill is passed, correct?
That's my understanding, but I'll defer to staff on that.
Yes, Lori. House Bill 4040, what Courtney shared was sort of the latest updates that it includes. Of course, the legislature could make additional amendments and may or may not pass it before the end of session. That is still to be determined.
Chris.
Yeah, Sarah, it doesn't relate to the short session. I know it's really hard in the short session, but in the longer sessions, we've had like legislative updates as part of board meetings where I don't remember, I'm not recalling in the moment what that person's name was, but they would come up and sort of at a high level kind of talk about the bills that we're working through and whether any of them were related to PDAB, and then we could communicate via email or things like that if we had further questions about it. I understand that's a challenge with the short session, but next year, is that something that we could continue?
So that probably would have been Jesse O'Brien, DFR's policy director. And that is definitely something we could discuss continuing for the long session next year. We'd really look to you all if there is, additional legislative recommendations that the board wants to make for potential statutory changes in the future. We can certainly have some conversation about that and determine if the board wants to make any recommendations in advance of the 2027 legislative session.
I'm
as you know, the people who are successful.
To like our recommendations and more just big things that we're kind of working through the legislature.
Oh.
So if we were thinking about recommendations or things, like we were in the loop on what was sort of currently part of bills going through, not less around us making recommendations or getting things to be part of bills, just so that we weren't duplicating efforts, or I don't know, in the broader perspective, knowing what legislators were talking about. I mean, Dr. Hartung, does that sound familiar, what I'm saying?
Yeah, and yeah, so that actually that's a great point, and thanks for bringing that up. And I don't know, yeah, it sounds like it's a capacity or resource issue about having that person, Jesse O'Brien, come and give us basically updates during the short session because things are happening so quickly. I just don't know.
Yeah, Jesse is considerably busier than the rest of us these couple of weeks. But that is something, again, and I really appreciate, as I'm still learning, and I appreciate your advice and your understanding as I'm learning how these state legislative processes work. That's something I'll go back and discuss with Jesse and see what we might feasibly plan for the long session for next year. I don't want to pre-commit to his capacity, of course, but I will definitely take that conversation back and see what we can do. At a minimum,
just so you know, Sarah, it was not like an hour. I mean, he would come on and hop on for like 15, 10 minutes and have some highlights of things, just so that we knew, hey, PDAB is getting discussed here, or here's all these other things that have to do with PBMs, et cetera, that are working their way through the legislature right now.
Yes. Yeah, that's a great suggestion. I will discuss it with Jesse and circle back with the board. Not sure if it'll be at our March meeting, but well in advance of the long session next year, we'll touch base. And as you're planning ahead for next year's long session, if there's additional legislative recommendations that the board wishes to discuss, the sooner you start those conversations, the more effective you can be.
Great. Thank you for that information. Any other board members have concerns or comments about this notification process? Board member Kennedy, Dan Kennedy.
Yes. Thank you. I don't have any questions about that. I just have a basic general question about HB 4040. The part of that asking the governor to appoint chairs for boards, was that PDAB specific, or was that for all public boards?
That's a great question, Dan. I can answer that real quick. So actually that was specific to PDAB.
Oh, okay.
So that in the bill, it specifically indicated that the governor would select the Prescription Drug Affordability Board chair.
Thank you.
Okay. I don't see any other. Oh, sorry.
Again, staff will certainly continue to monitor activities in the remainder of the short session. I don't really expect new bills to be introduced, but we will let you know what ends up happening with the language currently in House Bill 4040.
And I think there's, I haven't looked through the entire piece of legislation, but I think that there's, 2 tiers of information that the board probably should be appraised of. And one is like things that directly affect our governance, and that seems like a big deal. And procedures, like the other piece we haven't really just talked about is the insulin changes, which basically changing it, giving us more discretion on whether we want to identify insulin as an affordability challenge versus making it required And I think that's a reasonable change. So, and then the other piece is like, as a board member Lehman mentioned, just other things in the ecosystem that we should probably just be aware of, which is maybe a bigger ask, and especially as these things are quick moving.
Yes, Vice Chair Hartung, that's the area where I can't guarantee that we'll always catch everything, frankly. At a minimum, we can identify things that directly impact the PDAB authorizing statutes. We'll certainly share information where we can about other parts of the healthcare policy, but that can be complex.
Definitely. Okay, are there any other comments that people want to share or talk about this issue? Oh, board member Coder.
Dan, were you referring to the governor's advisory board for Medicaid outside of the legislative process this year?
I'm not sure I understand what you're talking about.
Yeah, I think that, it's one thing to be aware of what's happening in the legislative session, but there are other conversations that are occurring that may potentially impact the work that we do or how we look at that work. Specifically the Governor's Advisory Council on Medicaid that was implemented due to the federal reductions. So it would be great if we could get updates on those conversations if they are relevant to our work.
That definitely sounds relevant. And I would just have to again defer to staff in terms of capturing the breadth of policy discussions and reporting them back to it. Because yeah, it's like I don't know how to integrate that into any sort of process. I don't have any suggestions, but I'm open. I think that's reasonable.
And good. To follow up, Michelle, thank you for flagging that for that committee. If we do find anything that's relevant to the work, we need to, as staff, determine how we would get involved and to understand where that comes from. But we appreciate the flag.
And I just want to say I'm sure the governor's team will be putting out general updates in due course about their work. I have heard that it exists, like Michelle. I don't know a lot of details about what it's doing right now.
Okay. Any other comments about this issue? Okay, great. Thank you for your contributions to this discussion. The next item on our agenda are recommendations to include in the 2025 drug review report. And so now the board will, let's see here. Sorry, let me find my place. Yeah, we're going back to Courtney to basically discuss this issue about if we want to include recommendations in our report on drugs that may present affordability challenges that we identified for 2025 cycle. So Courtney, I'll let you take over for this discussion, or at least start guiding the discussion.
Yeah, again, I apologize for technical difficulty. You probably saw me jump out for a minute. I have some connectivity issues and my system is running very, very slow.
I think you caught what I had.
Yeah, thanks for sharing that. All right. And it sometimes doesn't help that I have so many windows open.
So I think the basic discussion while you're kind of getting your slides together is the basic discussion that we want to have here is, we went through this process of identifying 4 drugs and 1 insulin product that may present affordability challenges. And then the question is, do we want to provide the legislature or other policy folks any additional recommendations about essentially what to do with that information? It's not mandatory. We don't have any sort of regulatory authority, but as a board of experts in this area, we can certainly provide recommendations. So it looks like you got some slides up, so I'll pause and let you continue.
Thank you. I appreciate you providing that initial setup for me. So again, last month we discussed kind of some high level recommendations that came in from various board members. Again, Chair Bailey and John, both who are not here today, did provide a bulk of those recommendations. I did want to spend a little bit of time with the board today because from a policies perspective, I just wanted to level set kind of some research that I have done just to see if we can facilitate the conversation about what could be most meaningful. And again, today's intention is not to make a vote. It would be meaningful if we had some staff had guidance about what policy language I could help kind of develop to put into the report itself. And hopefully the conversation that we're going to have about these will help facilitate that. But again, just being clear, there's no vote today on this. This is continuing the conversation because it was kind of, it was first introduced last month. We usually have a few months of conversation regarding recommendations, and I just wanted to, maintain the fluidity of the discussion. So bucket A was primarily suggested by Chair Bailey as the policy options. And these ones I found to be really more specific to drugs, to one of the given drugs selected. So for example, and please, from your professional background, this is where you need to correct me if I had developed an analysis that isn't exactly what's going on in the market. But the drug I felt was most relevant to the no specialty tiers high was Cosentyx. And basically looking at what would a process be when, so if you were to make the recommendation, what would that process be? What would the policy perspective be to set it up? And one of the language kind of to consider would be to ensure that at least one clinical appropriate specialty or and then make it acceptable. I'm sorry, my notes are a little fuzzy here. So basically the language that I would develop would say something like ensure at least one clinically appropriate acceptable option exists on a lower cost sharing tier for drugs identified by PDAB as having a significant affordability impact. And so Chair Bailey provided a whole bunch of information on how her rationale was to suggest no specialty tiering for high cost drugs. But as I've been thinking about it, I think really just trying to focus it to the one drug for implementation. So before I I'm not making myself clear, this is a great kind of step in, but I just wanted to provide that you could do it possibly for Cosentyx. I think it might be a little bit challenging for the other drugs, but I wanted to open it up before moving on to the other ones, if the board could lean into a recommendation that kind of followed that consideration. And I might be able to cut it in so you guys could see what my note says here. And you can just read the language out loud.
Yeah, thanks, Courtney, for that background. I guess my first question for the board would be, do we want to provide, we're not under any sort of mandate to provide recommendations beyond just flagging these drugs as presenting affordability challenges. And so I guess before we go down this road, I just want to get the pulse of the board about, do we even want to go here in terms of providing additional recommendations?
And I think before I put language up, this should probably be a conversation. I don't want to lead the board to feel like we
Right.
have to make
Yeah.
a recommendation.
Yeah, no, appreciate the details here, but let's take the first step. So board member Lehman, see your hand.
Yeah, I think I agree with the concept or like the goal of wanting to provide a recommendation, Dr. Hartung, along with the hey, these are the medications we have studied and feel create affordability challenges. But it's hard for me to, and you'll understand this being in academia or just a pharmacist by background, like to make it a recommendation, I'd want to like have some data and historical like proof that there's efficacy to this recommendation. And even in what Chair Bailey described, I went and read the New York laws and the things in different states, but there isn't information yet to really show the impact or efficacy of these recommendations. And so if it were a format like potentially these options, if further investigated or something like that, these could be things, or these are things other states are doing, I could get behind that. But it's going to be hard for me to put my name behind a recommendation without, really understanding the full impacts. I think the person from Regents articulated it really well, saying, hey, there's all these other things that you guys have to think about with that recommendation. And until that further investigation has been done, I could sign off as like this is something we should look into, but it would be hard to say I endorse this as a recommendation.
Yeah, no, I agree with that. I think board member Coder, I saw your hand first, maybe, I can't remember.
I agree with board member Lehman. I have nothing further to add.
Okay. Board member Hoagland, I saw your hand next.
Yeah, so a couple of things. I think that we definitely just presenting medications without any sense of how you might make them more affordable would be, unfortunate, because I don't think anything would happen without some policy cues. I liked what you had said, Courtney. The wording here, no specialty tiers, for instance, for high-cost chronic drugs, sounds a little bit too non-specific. Not that you need to direct it to the specific drug itself, but the idea that you mentioned in your language that there would be a medication that was not on the specialty list, so that there would be something, to think about for the legislature and changing the overall potential cost of high cost medicines. So, I do think some suggestions about ways that they could look at or directions to go would be helpful, I guess. And my worry, if it's based totally on studies, that may be a time constraint because it delays being able to give this information before the long session.
Right. Okay. Thank you. Board member Kennedy, I see your hand.
Yes, I mostly just wanted to agree with Dr. Lehman. I don't think that we've got evidence to support the recommendation for no specialty tiers for high-cost chronic drugs. And I think without evidence, we need a more collaborative approach. I'm really concerned about unintended consequences if any of these recommendations are adopted, and then we find out later that it indeed had an opposite effect on the cost to consumers.
Great. Thanks for that comment. My perspective on this is that I also, like Board Member Hoagland and some others, sentiment that providing their drugs without any sort of additional guidance in terms of just general things to explore, I feel seems a little empty. And, I feel like we have opportunity to provide some reasonable things for the legislature to consider that are specific to a drug. Specific to the drugs that we flagged during our review process, our year-long review process. I'm pretty uncomfortable with some of these things in terms of their pretty sweeping nature and perhaps overly micromanaging kind of utilization management, formulary management, and things like that on a broad scale, at least as written in some of these bullets. But I do think we could craft some very specific drug-specific recommendations that are, again, specifically yoked to our the drugs that we identified in our process. And I think that would be something that I would consider. And what that is, I guess we can have that discussion now, and then if we can come to some consensus, I think the process is, if we can come to a consensus about what those recommendations would be, we can have staff work them into the report that I think we vote on for next in March, next month. But I also, I firmly agree that, some of these things might have unintended consequences, and also intended consequences. And the sentiment in public comment about, we're doing difficult things, and I think we don't. I think we should be kind of, I don't know if bold is the right word, but creative in terms of innovative in what we're recommending. We don't have any authority, but we can rely on our personal expertise to make recommendations, at least. So yeah, I would like to see something additional added to beyond just the drugs flagged in the report.
And to clarify, Dr. Hartung, or Vice Chair Hartung, that is something that I kind of try to work on to help facilitate the conversation, because again, I know that these are really high level. Would it be okay if I added in my suggested analysis and just to kind of facilitate for a couple of these bullet points?
Yeah, absolutely. I want to hear what you have prepared and thought through, or we want to hear that.
All right, and I know this is really tiny. Hopefully you can. All right, for the first one, again, just from an analysis, trying to do some cross-referencing of information, but this is where I lean into the board's expertise. But something that was considered was, or to consider, is ensuring at least one clinically appropriate accessible operation exists on a lower cost sharing tier for drugs identified by the reuse process as having a significant affordability impact. So that was just one concept. I'm still trying to strategize like how that would be implemented so it doesn't show impact. And I think, from a policy perspective, that's the lens that I approached some of this at, but I definitely would think that the board can help provide a lot more guidance in this process.
Okay. Yeah, so and again, I'll open this up, I'll just make my comments briefly now, and then board can discuss as well. But I don't particularly like this these first two bullets, in terms of just, it seems to me kind of micromanaging the complexity of formularies across the span of health plans seems like a difficult task to do from a legislative perspective. Now, specialty tiers are kind of, drugs get into specialty tiers because at one point they were specialty drugs and now they're just like more expensive. So it's just coded as spendy drugs. And so, and I think that drugs that are in those higher tiers typically are managed more by utilization management techniques, as well as patients incur higher out-of-pocket costs, which I think we identified as board as being like one of the, that's one of our charges, like identifying drugs that have high out-of-pocket costs, and patients are maybe experiencing toxicity, financial toxicity because of that. So, if I were to move forward with any of these or think about any of these first two ones, I would say, consider out-of-pocket cost caps on drugs that we identify as having affordability issues, of the nature of high out-of-pocket costs is kind of how I would reframe this set of recommendations. So that's my thought. I saw a hand from Board Member Coder, and I see one from Hoagland, Board Member Hoagland right now. So Board Member Hoagland, did you have a comment? Your hand is still up, so I'll let you.
So I guess my comment being that one of the things we heard from our letters to the board is the challenge of changes with health plans and formularies that make it difficult for patients to continue with a medication over time. So I think that there needs to be some form of regulation so that people have a little more confidence when they're starting a medicine, if it works for them, that, a year or two from now, it's not going to be prohibitive and they'll have to figure out another option. So, in that sense, I think both the formulary stability point as well as the specialty tier point looks at regulation of health plans, which seems to be a problem.
Other comments, Board Member Coder.
I agree with your comments regarding specialty tiers. I think that would be a low impact recommendation because those tools already exist with utilization management requirements before you get to a specialty tier. The formulary stability piece, I worry about mandating that because there will be opportunities that develop throughout the year, and we can talk about requiring grandfathering provisions, but there may be opportunities that health plans need to take advantage of in order to control their own costs. And so the market is so dynamic that I worry about just putting a blanket recommendation that plans cannot have any mid-year changes.
And Michelle, that's kind of how I perceive that. And I'm trying to get my thing to paste in here. This is some of the policy languages that I was working with. So it doesn't provide such a narrow scope. Hopefully you can see that. Sorry, editing in real time is a little challenging. I'll give you a second to read kind of what that consideration option would be instead of just blanketing, but providing some stronger guardrails to consider. So it's not as impactful to carriers and stuff like that. And something else to consider is maybe having the requirement just for the drugs identified by the board instead of like the whole entire stream of drugs.
I'm sorry, you were breaking up a little bit when you, that last sentence, Courtney. Could you repeat?
Yeah, I said another thing to consider is providing this recommendation as just associated with the drugs that are identified instead of the whole drug system. So it's a
Okay.
small implementation versus a very large implementation for our carriers.
So the operationalized would be no formulary changes for drugs that we identified as presenting affordability challenges.
I have to admit, I really struggled with charitable pharmacy coming up with any language or the CVI because it's I don't have enough insight to understand their dynamics of the system. I did have some language, and Sarah, I see your hand up. I'm sorry, go ahead. Why I pasted some of this other consideration of language.
Yeah, just one additional thing I wanted to add for board members' consideration on the insurance coverage discussion. I think some of the patient comments we've seen and some of the issues you read about in the press are often mid-year formulary changes are one thing, and I very much understand how patients find that really frustrating, but many people change their insurance plans from year to year, either voluntarily or because the plan they previously had is no longer offered and their employer or their carrier has changed the options that are available. And many of those instances where patients encounter formulary shocks that cause challenges for patients can also be associated with plan changes. So that makes talking about any policy around formulary changes complicated if you're also having to consider situations where individuals change their insurance coverage.
Board Member Kennedy.
Yeah, that's a really good point, Sarah. I would say, though, that for most health plans, there is a continuity of care provision that will allow them to remain on even high-cost drugs for a limited amount of time. So that's something to consider. Clinically, continuity of care, I think, is really important for somebody that's on any medication that is changing plans.
And yeah, no, I agree. And Courtney, your point about the charitable pharmacy access and this social vulnerability index to inform copay affordability concerns, or any, like, you know, I read that as like kind of means testing some copay or cost sharing structure. So patients who are kind of less afford cost sharing have to pay less. I absolutely hate cost sharing for chronic medications. And I think that we can do things to if we can do things to mediate that or mitigate that, I think that would be one of my preferences. And I don't, for me right now, those two bullets, I don't think we need to my bias is we don't need to pursue any sort of further delineation of proposals related to those things. So that's just my opinion. Board Member Hoagland.
I feel the same way, Dr. Hartung. I feel like when you look at the SVI across Oregon and you realize that it's regional, the complexity of administering something like that doesn't make sense to me. Just the cost alone and the fact that will change over time. You'd have different cost depending on the region of Oregon you lived in.
Okay. Okay, good. So where are we now? So Courtney, should we move on to the next bucket? Just to kind of
Yeah, I
maybe
can
try to
move on.
eliminate some things.
In just a second, I just want to just step back for a second though, because the considerations that I put up, we really haven't had a discussion about if that is similar language to even consider. Again, I for official vote, but at least having a sense if this is what the board would like to have in the report. So as we kind of create that finalization of the report to get finalized. If we want to delete it out of the report, that's fine for next month. But if it's not meaningful enough to carry forward and put into the report, I would rather leave it out at this time. So if we can spend a little bit more time kind of either finessing the consideration or any of the language, or if there's any absolutely no-go recommendation to be in the report.
Okay. No,
So kind of
that's
starting
good
back.
to let's figure that, let's make this decision here. My preference is not to include any of these changes. Because I feel like they're not specific enough to again, the drugs we flagged as affordability challenges. And, you know, going back to our language, affordability challenges relate to both the health system and high patient out-of-pocket costs. And so, you know, to get at high spending at the health system level, you know, I think that would require one of these kind of hot button issues about reducing the acquisition costs of the drug, i.e. like upper payment limit, things like that. To reduce out-of-pocket costs, which is again something that's spelled out in our charge, you know, I think we can consider things like out-of-pocket caps. I mean, these are things that have gained traction in the insulin field. There are other states that are exploring out-of-pocket costs caps for other specific drugs, inhalers. The Medicare Part D program has now a cap on out-of-pocket costs just in total. So it's definitely has some legs in terms of actually implementation. And sure, yes, will it have unintended or probably intended or not intended, but anticipated effects in terms of premiums among other folks? Probably, but depends on the scope of the drug. But I think it would definitely alleviate at least some of the cost sharing concerns of people who are taking some of these very expensive drugs and are hit by maybe in some cases thousands of dollars in out-of-pocket drug costs for one drug. So that's my policy recommendation preference, but that's just me. What do other people think? Board member Lehman, I see your hand.
I mean, I think I'd like to go to the next page, Dr. Hartung, and keep talking about it, but I agree with what I think your recommendation was, that these three are not, like, I would agree to not include any of the, I mean, we've already crossed out two, like the three remaining or the five that were on this page, and then go on and continue the discussion like we have just had with these five, with the ones on the subsequent pages.
Okay. I think it was board member Coder, you're up top of my list.
I agree with that recommendation. I do have concerns with putting caps on out-of-pocket costs, specifically, you know, in the way of co-pays or cost sharing, because I think those costs will be transferred to premiums and deductibles. So ultimately not really lowering costs for the consumers. And so I think we need to continue to have conversations about the actual cost to the system, which drives costs to consumers.
That's very true. Board Member Kennedy.
Yes, I was just going to agree with Dr. Hartung that I'm okay excluding everything in bucket A from our report.
Okay, great. Thank you for being explicit about that. And I think sounds like everyone's on the same page that we can just like move on from bucket A. We're not including it in our report. Progress. Okay, good. Bucket B.
All right. No bucket A, onto bucket B. Again, because this was a little more high level of information and primarily focused around study or further investigation, it was kind of challenging to come up with policy or implementation dynamics, which is, again, hopefully we can have a meaningful conversation if there's anything specific. There were some concepts that I thought about regarding the PBM, like rebate dynamics to maybe lean into, but I want to first hear from the board what your primary interests or non-interest are in this bucket.
Okay, great, thank you. Bucket B, do board members have thoughts about bucket B, any of the items? Board Member Kennedy.
Yes, I'd like to speak to vertical integration, and I know in other states they have outlawed PBM ownership of pharmacies, as seeing that as a major conflict of interest. And so I think vertical integration is very key to lowering costs, out-of-pocket costs for consumers. I think when there's vertical integration, I think there's lots of mischief that can be played within the system to game the system. So I think that's something that can be left in there in terms, if they haven't considered it, that they should consider not allowing ownership of downstream entities for PBMs.
Yes, I completely agree. Mischief abounds. Other board members, thoughts on any of these items, concepts? Board Member Coder.
Recognizing that Board Member Murray is not present, was the PBM conduct and rebate dynamics the delinking conversation?
Yeah, it was associated with that. And one of the concepts that I kind of leaned into from because that's actually the one that I was able to kind of lean into the most, basically require that PBMs to report net pricing into drug price transparency program. So any aggregated or trade secret confidential information would first be vetted through them, just like what we do with the manufacturers, and then submitted over to board for additional consideration. But basically really focus in on collecting the net price information. Let me pull my note on that. And collect information regarding ingredient cost, rebates, administrative fees, price concessions, and price and spread pricing, and it'd be focused specifically on PBM reporting to DPT.
Okay, thank you for that clarification. Board Member Hoagland.
So it sounds like that's all PBM conduct, even the vertical integration comment that the PBM could not own a pharmacy. So maybe listing those things with PBM conduct, which involves also this spread pricing and delinking and all those issues.
So if I was to change it to look like that, and then
Yeah, I'm having some trouble kind of figuring out what the specific, well, A, what the specific recommendation would be, and then B, why is it, again, I feel like this a recommendations, because we have an annual report that's got a lot of broad-based recommendations, and some of them may be similar to some of these things here. That I feel like our recommendations should be really targeted to these drugs. That's just my belief. In terms of like these concepts here, well, at least the PBM stuff, vertical integration, I agree it's very problematic. I think that there's some, the recent federal budget that passed had some language in terms of some of these concepts that we've been talking about, at least in the Medicare space, about PBM compensation, rebates, pharmacy access. And then there's also been recent, the Federal Trade Commission just recently settled with Express Scripts in a large settlement that, will require, it's not so much about the vertical integration, but about kind of list price, cost sharing based on list price versus net price, and pass through of rebates and things like that. So I think that there's a lot of regulatory action that's going to pass through the system through at least those two things. There may be further settlements with other PBMs coming down the pike that may make me a little bit wary, in addition to recommending something in terms of like broad scale change, recommendations about the ecosystem within this report. So yeah, that's my opinion. I'll just say that copay accumulators, maximizers, I think maybe I recommended that, or I talked about it, but I think that there are some regulatory prohibitions around that kind of thing in Oregon already. So for that reason, I don't know that that needs to be retained as a concept. Board Member Coder.
Vice Chair Hartung, are you suggesting that we wait and see what the impacts are of what's happening at the federal level in Medicare before putting forward any recommendations for the state, or?
Yeah, basically, saying not go there on this specific report.
I agree.
Board Member Hoagland.
So two things. One is CAP, as I hear you mentioned, Dan, recommended for this small group of medicines as a possible way of addressing their specific cost. Might be something we could recommend. And then the other question I had was competition effects, what that refers to. I wasn't sure.
Yeah, so that's if we're going to do anything, my thought is to provide some recommendation around cost sharing caps. It doesn't have to be very direct prescriptive, no pun intended, but just maybe that there's some exploration of that as a possible something that we can do, or the legislature could do, based on our identification of these drugs. and we don't have to provide it for some drugs I think are affordability concerns for the health system, and then some for the patients themselves. And I understand that capping out-of-pocket costs could have, you squeeze the balloon one place and it pops up in terms of premiums overall, and that needs to be considered. But I'm also very sympathetic towards individual patients who experience very high out-of-pocket costs. And so, any sort of smoothing of costs across a broader population seems to be a move towards kind of equity. In terms of the other, if you want to go back one slide, Courtney, in terms of this competition effects, I don't know what that means, or what that's referring to.
And again, that was a recommendation from John, and even in the write-up, it wasn't incredibly clear. And since he's not here to provide content, there's not much else I can provide insight on for that.
Well, maybe we put that, like, I'll put a pin in that concept or these concepts, because again, we're going to be doing our annual report at the end of next year, and we can revisit some of these larger concepts for consideration in that report.
Okay.
That's what I think we should do.
Any feedback from other board members?
Yeah, any
Just
other
put a pin in this and read.
dissenting opinions?
All right, not hearing any objection, I'll guess we'll go into the next slide. So none of these will be, just to clarify, none of these will be incorporated into this report either. So going on to the next slide. Dr. Hartung, you want to run with the first two, and then Michelle, if you want to cover the second two.
Sure. So I mean, I'm kind of beating my little hobby horse here in terms of I don't like cost sharing for chronic medications. And I realize that, that's just the way it is. But I think we do have some authority, not authority, but some expertise to recommend that maybe we could do something. We could recommend the legislative change to cap out-of-pocket costs for certain targeted drugs that we think are maybe excessive. So that's the intention of I think bullet 1, and then bullet 2 is more in line with that. And I think my thought with the second bullet is just bringing down out-of-pocket costs in general. And I think, for my comments a couple of minutes ago about some of these big changes that are happening, both from the Medicare Part D market as well as some of these legal settlements that are coming down the pike, that there may be some changes in terms of delinking list price from cost sharing tiers and stuff like that. So I think the second bullet, I'm fine with, if that was my submission, so I'm fine with withdrawing that, and it's just kind of sticking with my main point about out-of-pocket cost caps for identified drugs. But I will open the floor. It's always open, but open it explicitly for other board members for provide comment. Board member Coder.
That last bullet point was just a brainstorm that I had about whether the state has any authority to create inflationary penalties similar to what Medicare and Medicaid get for other types of health plans. And I don't know the answer to that question, but I thought it might be worth exploring.
And Michelle, just for clarification, I appreciate you saying that, because I was kind of looking through these and evaluating, I'd say that it's fairly challenging. I think further study or, additional, like especially the feasibility evaluations, kind of how that would be incorporated would need to happen. Not to say that, again, this is where that creativity and where once you have something creative, you can kind of finesse where and how and stuff like that. Because I think that there's a lot of study potentials. And I think that's the other thing to also consider as a recommendation is that there's additional studies that needs to occur from what has been identified of the drugs that were selected. So I know we've been really focusing on, policy recommendation or how we, but maybe leaning into, are there other things that can be studied or more, consideration, kind of like what, when we were authorized to do that for payment limit study.
Yeah, I think this is an intriguing idea. I guess I wonder, and I would, support any sort of, doesn't even have to be a big study, just like I think people have probably written about it. And the other thing that I wonder is like, Medicaid's been using the inflationary penalty for decades now, and then they recently lifted the cap on basically this inflationary penalty. So potential manufacturers with branded products that have been branded for a long time, will potentially have to pay back or pay state programs for the use of their drug in that particular state. And then I know Medicare has just recently adopted a similar thing. So part of me wonders if like those two, behemoths in the healthcare system provide enough heft to kind of like distill out these, egregious increases in price that were, I think they were common like 10 years ago. You'd see 10% per year increases year over year. And that was something you'd see, but I think because of the Medicaid inflation penalty and now the Medicare, it's become far less common to see that stuff. And now I think Board Member Coder, you brought up maybe at the last meeting or the meeting before that companies are responding in many ways, reducing their WACs to try to, I think partially to escape some of these pressures. So yeah, complex. I think it's worthwhile thinking about it, and maybe having staff provide some sort of summary of kind of like the landscape around this stuff and what other people are thinking about it. But in terms of like putting it on this report, I think that maybe it's a little bit not quite ready for prime time. Other thoughts from board members? Board Member Kennedy.
Yes, I guess in my mind, explore and evaluate are not policy recommendations. Those are more things that we could look at, but not necessarily things that the legislature would look at. My 2 cents.
No, I agree. So I think, but we can direct staff to at least prepare some reports or some sort of synthesis of kind of the current state of the art of some of these concepts if we want to consider them in the future. I think but we don't need to like notify the legislature that we want to do that. We can just do that. Cool. So okay. Oh, I see Board Member Lehman.
Yes, it sounds like we haven't voted, but we're landing on that targeted caps on out of pocket. So that is going to address the affordability issue for the person at the pharmacy counter getting these 3 or 4 very expensive medications that we listed. Is there something that we could recommend Dr. Hartung, that is a more global sort of reduction across the health system that would actually address some of the cost concerns? Because I think to Michelle's point earlier, and your point when you're talking about that balloon, that shifts cost and creates equity, but it doesn't really address the overall cost in the system, if that makes sense.
No, I mean, that's a great point, and I'm open to people's thoughts on other things that would address more globally that notion. Certainly like other PDABs and other states are moving forward. At least Colorado is moving forward with a limit on acquisition cost on Enbrel, I believe. And some states I think are experimenting with, like, they're more global, but like pharmacy spend targets for the state, and if there's exceeding targets of certain of spend, then they move on to the next thing, which I'm not sure what that is. But yeah, I'm open to thoughts about like what other things could we recommend that would address healthcare system spending and solvency with respect to prescription drugs.
And I'm not an expert with regard to the delinking piece. And I don't know if you can do it for just 3 drugs, but like getting away from list price for those 3 drugs and having to make payments based on a different price. I mean, you're more of an expert in that area, I think, Dan. I don't know. Is that something that's feasible or possible?
Well, for me, that's one of these things that's I think is coming down the pike and is probably evolving right now as we speak in terms of PBMs,
Okay.
getting out of that big rebate game just globally. And to me, what that does, it just reduces, out-of-pocket costs for patients. So if we can just get there more directly, we already have stuff on the books in Oregon about, I think about rebates being passed through to the payers, insurance programs. So we think, and we've seen some data about, like, we know PBMs are passing through those savings. So there's no, at least that's not a mechanism that is being used to kind of boost their revenue per se. There's probably other things, but it's moving away from that. So, but my read on that is just like it's a way to, like, if your cost share is 20% of the list price, but you want to change it to 20% of the net price, that's a out-of-pocket savings for the patient. Board Member Hoagland.
So currently, we have a structure where the Medicaid PBM is CCO dependent as opposed to one PBM for all of the state. And I'm wondering if we mentioned, I think it came up at an earlier conversation of moving in that direction to having one PBM for all Medicaid purchases.
Yeah, that was a recommendation in our annual report. That the state pursue a single statewide PBM with a uniform preferred drug list. So, we
don't need to mention it.
Yeah, I don't think so. I think we still agree with that, but our recommendation still stands.
And that's fair if we don't have one, Dan. I think I wanted to put it out there that it's a gap sort of in the recommendation that it's not the global costs of drugs. It's really just the person at the counter picking up their medicine.
Right. For this third bullet.
No, I'm talking about what it seemed like what we were landing on, or what you were recommending was using just the first bullet. And so that's as the recommendation, and that will address the costs at the counter for somebody, but it's not gonna, but those costs are going to shift, right? Because I would guess that the payers are just going to increase premiums or things like that because they're not collecting as much at the counter from the patients, right?
Yeah. Yeah. And the degree to which is unclear. And I don't know if it's going to be like for one drug, if that's going to move the needle on premiums for payers. I have a hard time believing that, but certainly writ large, I think if you look at the Medicare, they've implemented caps and they're shifting costs from patients to the government and premiums and things like that. So I think it will occur, but the degree to which it's not clear. It's not like we'd be recommending, across the board caps. It'd just be very targeted.
No, and these are meds that we studied and we know provide affordability challenges. So, I mean, it seems like a very targeted recommendation for the 3 drugs that we voted on.
That's my perspective.
And hearing that from the board members, I can take that one back and do a little more study to kind of shore up for a further conversation next month. I could also, since there was quite a bit of conversation about the D-Links PBM payments, if the board would like, I can do a little bit of research on that as well, to see if that's a option to also consider to have in their report. But from what I'm hearing, it's primarily leaning into the first bullet there, which is, targeted caps and what would be a meaningful kind of policy process recommendation to include in the review report. Is that what I'm hearing from kind of the guidance? I see Michelle's head nodding, a little bit of everybody's. Okay. I can take that and run with
Courtney,
that.
I would say also I agree, but I would also say if we could prioritize the out-of-pocket caps for the next meeting, given that that's what obviously this may be obvious, so that we'll need to vote on that. And then I feel like this other piece, the delinking PBM payments and just like understanding the landscape for what's changing, that might be something that we want to flag for our next annual report. So maybe we don't need to. I think it's something we, staff can kind of look at and kind of prepare some information for our board, but maybe not prioritized as high as this other one for the next meeting, if that makes sense.
Absolutely. That gives me more time to focus on what that recommendation concept would look like. So
cool.
And then is there any other conversation on recommendations that the board would like to have? Otherwise, we have just one solid recommendation. And I believe we can also probably take a break if we're going to wrap up the conversation.
Maybe in addition to this delinking thing, in terms of like further study for in the year, per the comment that board member Lehman addressed, was the notion of other things that we might do to address kind of high system costs, other interventional type stuff, policy recommendations. Maybe we could kind of yoke that to this PBM delinking thing as well. Just say, just so we know we have something teed up for the next time we have to do this.
Okay.
Board member Hoagland.
Yeah, so the other thing I think about, which relates back to the charitable pharmacies 340B programs, is the concept of deserts, so that the thought might be to look at access across the state so that there are places that people can get their medications for less cost. I'm not a pharmacist, so I don't know how possible that is. But when I looked at the charitable pharmacies across Oregon, there did seem like there was some areas where they were clustered quite heavily and other areas where there were none.
Yeah, I really don't know a whole lot about charitable pharmacies and like what they are, and but I'd be interested in hearing more about that as well in the future. Board Member Coder.
So charitable pharmacies are able to receive donated medications. So for example, long-term care homes for individuals who no longer need those meds and then redispense them. The Board of Pharmacy requirements for charitable pharmacies are pretty onerous, and I believe that's why we don't see more of them.
Interesting. So it sounds like on the margins, they might be helpful for some specific cases, but both access and like the availability of medications at them might be pretty limited. Board Member Hoagland, go ahead.
So, one thing that came out of the recent legislation federally is kind of some boosting of 340B pharmacies with federally qualified health centers. So, I think if we look at things above and beyond just charitable pharmacies, but the concept that people have the access to make choices to, get their medicine from different places, that could also help with the equity issue.
Okay. So it sounds like, are there any other comments? And sounds like we might want to take a little break before we go on to the next agenda item. But any other issues before we break? Okay, cool. So go back to this. So let's take a 5-minute break. It is 10:39 now, so let's just say 10:45. 6-minute break. And then we'll reconvene after that. So thank you. All right. Do we need to recall the roll at all?
Yes, I can take a roll call, confirm a quorum. Vice Chair Dan Hartung.
Present.
Lori Hoagland.
Present.
Dan Kennedy.
Present.
Michelle Coder.
Present.
Chris Lehman.
Present.
We have a quorum.
All right. The final item on our agenda or discussion item is we will continue the discussion of the 2026 drug review. At the December meeting, staff presented the draft preliminary lists of prescription drugs and insulin products for the 2026 review based on commercial insurer reporting from calendar year 2024. The board discussed the lists during January meeting, and staff brought back revisions for the board review today. A new dashboard and updates to the Excel sheets have been posted on the PDAB website with links included in today's agenda materials. And as usual, Courtney will lead our discussion of the subset list.
Thank you, Vice Chair Hartung. Before we jump into that, I did want to just share screen real quick. Or maybe not. I don't know why my thing keeps doing this to me. Just to level set kind of where we're at in our roadmap. So in February, again, today we've had a really great discussion about the report, and there's no specific feedback regarding the report that was written, and the conversation around the recommendations, of which staff will go back and vet thoroughly on the one that was decided to go forward. With the vote for the approval, being next month, and within that vote, it will incorporate that final recommendation. Today, we're going to start jumping into the 2026 preliminary list, both for the prescription medications and for insulin products, and accompanying that is the dashboard. So I just want to make sure that that's, the process is continuing to be understood, that where we're at, and then what the expectation is for next month. So with that, I am going to stop sharing. And I'm actually going to lean into Hay and Heather as the data analysts and data researchers to kind of help facilitate some of these discussions with the preliminary list and the insulin products. However, I do know that we're all kind of experiencing technical difficulties. So if we have to go off camera, please know that it is because we are having huge lags in our systems. I did want to set up first board. Is it easier for the board to review the products based in the dashboard or on the spreadsheet, both of which are provided on our website?
So I like the dashboard. I was using the dashboard. I've always been using the spreadsheet, but the most recent iteration, I was using the dashboard and found it to be extremely nice to use. So that's my preference at this point. But either or, I think some stuff maybe we can go back to the Excel if it's easier to see there. But
okay, I do have both of them pulled up. So
what's easier for you guys to navigate?
For me,
Okay.
it doesn't really
Okay.
matter. Okay, and are you able to see my screen that says the dashboard navigation on it?
Yes.
Because, all right. So since this is a new dashboard, and again, if I say anything that needs additional clarification, please jump on. But just as a quick overview of the dashboard and this product, you have just kind of our functionality tabs along the top, document history. Since this is version 1, there's not much in it. Sources provide kind of where what fuels the information and kind of the websites most utilized for information that we collect within all the drugs reviewed. Definitions, since we have a few acronyms within the dashboard, everything's kind of spelled out, and then additional clarification for languages used throughout the data processing. And I don't think right now it is necessarily alphabetized, but it's there for you. And again, and then this notes anything that is relevant to the collection of the data or the setup of the aggregation to get to the preliminary, for both preliminary lists. So those are just a high level of what those upper tabs represent. Kind of like last year, they're split out between carrier preliminary data. This again is your net data information. Since it is reported primarily by the 11 reporting carriers into the Drug Price Transparency Program. Insulin data or information is based off of gross price, so because it's collected from all payers, the all claim all payers, or the APAC data set. So before jumping into any specific tab, does board members have any recommendation or any questions for staff and how this was initially set up? If nothing, then what tab does the board want to jump into first?
I have a question just for the board to discuss in terms of like what our ultimate goal is in terms of the number of drugs and like how much time we have, just so we can kind of have a sense of like what needs to be on the subset list now that we have a year of experience and kind of putting these things together. how much time, like how many meetings are we gonna have to review the drugs this year relative to last year? We had 16 drugs last year and it felt a little bit unwieldy. And so I'm wondering if we need to target fewer drugs.
And just to level set, again, we did have statutory change that the board can select up to 9 drugs, so probably don't have to select as many drugs. And with that, you know, the process should be, again, looking at whatever seems to be the most impactful. I think, you know, also leaning into immense amount of information that's in the annual report regarding the trending of drugs. So, you know, there's lots of high impact drugs that were kind of fell off due to kind of some of the drill down. So again, and one of the reminders is that every review cycle does not have to be the same as the previous year. There can be changes in, you know, whatever you feel is the most relevant for this year's cycle to review.
No, I appreciate that. And I definitely think there's more than enough drugs that, you know, deserve our attention. It's just a matter, do we want to like a priority set a upper limit of drugs that we instruct staff to go on and spend time and then time that we have to review. So that's my concern, like just having a ballpark. So board member Lehman, did you have a comment?
Not related to that.
Okay.
Dan.
Okay.
And as a reminder, board, so that we can keep on our roadmap of information, a selection of drugs does need to happen by next month. So the conversations we've had the last couple of months is considerations of how the drug should be drilled out, but really staff needs to know by next month, preferably, what the subset list is going to be so we can send it on to the carriers for additional information. So I totally hear what you're saying, Dan, that, you know, trying to get to a drill down of a specific number can be meaningful, but I also don't want to shorthand any drugs that might be reasonably needed to be reviewed through any of the process that might be missed. So, yeah,
Right.
Chris, I see you.
Yeah,
Yeah,
so
but-
Dan, it's not an idea about the total number. It's more of a pitch on how to, I don't know, classify the drugs, which would in turn limit the number. So there was public comment, I think Charlie Fisher was the gentleman's name, but it's an idea that's been resonating kind of in my head for the last year as we've been working on this, which is, could we just focus on the drugs that are the Medicare price, max price drugs, and then say, instead of for all of them, hey, let's try as a state on these 2 drugs. So assess all those drugs and say, in Oregon, these are the ones with we identify as the biggest challenge. Let's, in the state of Oregon, mandate that we're going to follow that Medicare max price across all payers in the state for these 2 drugs. And that could be our policy recommendation with it, if that makes sense. And then I think there's like 15 or so drugs that are on that list over the next couple of years. And that would kind of give us the starting place for how we chose them, because we know they're all high costs, affecting different amounts of patients, et cetera, and kind of go from there. But again, that was just an idea, not I don't know what the group thinks about that.
I mean, to me, it makes sense. And at the very least, I think there was some just chatter at a couple meetings past about, you know, not having to worry about them because Medicare was doing something, which I don't think is maybe a direction we want to go. But yeah, so I mean, I think that's one approach. I mean, as I was thinking about this in preparation, I was thinking in terms of the lenses of like, you know, overall healthcare spending and then patient specific out of, you know, spending, and, you know, maybe we want to like be strategic and like looking at drugs that have a high health system burden as best as we can at this stage. And then same thing, and then maybe another handful of drugs that are going to be more burdensome on the patient financial out-of-pocket side as a way of parsing it as well. And then, but I'm happy to, like, if, you know, that makes sense to like focus in on the Medicare identified drugs. I guess my question here is like, you know, Medicare just how current are we in this data set about the drugs that have been identified by the Medicare program? Because I know they do it yearly, and like they've just identified the next, I think you said 15. And do we have a good, is this data set calibrated in a way that we have a good visibility to all the drugs that Medicare has looked at? And Medicare, you know, they're just using like, you know, the basic is like, is there spend over you know, hundreds of millions of dollars, and some restrictions based on either generics or biosimilars. So I think they're kind of following a similar roadmap or we're following a similar roadmap to them. But in terms of like, you know, if we need to get to these drugs by next week or next month, you know, we had 16 drugs that we had staff prepare reports to, and that seemed a little bit unwieldy, and like we were rushing through it and staff was rushing to prepare reports because there's just a lot of information to parse. So my personal preference would be to have fewer, now that we have even more discretion to only identify up to 9, and we can do 0 to 9. So, you know, I had 12 to 14 maybe drugs that we could have staff put on our preliminary list for these affordability reviews as kind of something a little bit less than last year.
And Dr. Hartung, as you say that you've kind of already identified them, do you want to share your drill down methodology? And I can try to replicate it here so that it can be seen.
Sure. Well, I mean, it's very basic. So I just thought in terms of like the same exclusions we did last year, and we discussed, so excluding these toxoids, vaccines, and then drugs for HIV. And then, you know, we have net spending and net spending per enrollee. And so, you know, I looked at net spending as kind of the health system indicator, and then net spending per enrollee is possibly being tethered to out-of-pocket costs, perhaps. But again, we have limited visibility on those specific things. But that's the purpose of the affordability review, is to really drill down on that stuff. So, so I just looked at the total net spend kind of declining, and then looked at it again at total net spending per enrollee. And then this notion of the orphan drugs, like how we handle that, that's tricky.
And as your drill down, it excludes generics.
Right, yeah, just brands. And then I think we also exclude any brands that have current generic equivalents or biosimilars on the market. Makes sense. Or I think we have a field that's like expected generic equivalents or biosimilars in the next 18 months or something like that.
And then any previously reviewed on the subset list.
Well, that's a good question. Because, you know, some of these, our data are dated a little bit, and B, you know, there's changes afoot, and like, you know, the GLP-1s we kind of gave them a pass in the last iteration. But certainly those are going to be big ticket items for health systems to pay for. And I think part of the dynamics that are occurring now is like around coverage, like, you know, payers are limiting coverage, which is probably having some sort of limit on spend. And, you know, that's why you're seeing all these this traction with direct to consumer purchasing of some of these agents through, you know, with companies or Trump RX or things like that. So I don't know if we need to. I'm open to reviewing those, having those on the docket again, just if we want to like do a re-review of some of them. That's my
If they meet the criteria, gotcha.
yeah. So
And
Dr. Hartung, I have a quick question.
yes, yeah.
Yeah, my question is very basic, but sort of. So I'm curious. When I look at the subset for this year, is it going to include drugs that were on our previous list, or are we going to exclude those? So are we looking for additional drugs that we believe are unaffordable, or drug A, congratulations, you made the list 2 years in a row or 3 years in a row, or how are we going to do that?
It's whatever the board wants to do. I mean, I kind of like, I'm open to going down either path. Like if we reviewed a drug, like we reviewed Ozempic and Wegovy last year, but if we want to review them again, I'm open to that as well. Board member Coder.
My recommendation would be not to exclude drugs that were reviewed previously because market dynamics change fairly quickly. And so I think we would be remiss in having a blanket exclusion for drugs that we've already reviewed.
I agree with that, Michelle.
Board member Hoagland.
I agree also. I think they only have access to one report at a time, and if it's been a couple of years and needing to be on that list, it's significant.
Yeah, I lean that way as well.
So
right.
perhaps we could, sorry, Courtney, perhaps we could add an asterisk or something saying this drug also appeared on last year's list or last year's report.
Yeah, that information is in both the Excel spreadsheet and in here. But I hear what you're saying. If it's like an asterisk like next to the name, is that what you're saying? So it's easier identified versus drilling it out from this list. From this list. Okay, we can consider that. So Dan, you were kind of providing guidance with how you would
Yeah.
set up a kind of a review process. Currently at 52 based off of the removal of a couple of therapeutic classes, only focusing on brand drugs, and then removing any that do not have equivalent or biosimilarities to them. Is there anything else that I can utilize short of putting the columns in a particular order that the board
Well,
would?
I mean, I guess the one question is, we have Cosentix here, and we already flagged that as being an affordability challenge, and so maybe we don't need to. I mean, we could, but it seems like we already kind of planted the flag in that one. And so maybe it doesn't need to be reviewed or less priority. I don't know. Board member Coder.
Yeah, that was going to be my suggestion as well. I used the same methodology in my reviews that Vice Chair Hartung did. And with these filters, and then really started digging into the orphan drug status. I personally think we would be remiss if we didn't select several of the drugs that wound up on the DPT's annual report. And so, you know, Skyrizi, of course, was the one with the most spend, and I think it would be incumbent upon us to review some of those.
And I agree with you, Board Member Coder. You know, we haven't thought through the mechanism and the process for parsing out orphan and non-orphan indications in the affordability report, but I think that can be something that we work on during the affordability reviews, and it'll be a learning experience for staff and for board members to kind of address that challenge. So like Keytruda, I think we should go in on that. It has a variety of non-orphan indications where it's used a lot, and cancer medications are a poster child for affordability issues. So I think we'd be remiss with kind of shying away from things like that. Obviously, there are certain Trikafta as only one indication in CF, so obviously we will pass on that, but I think the rest we can proceed and try to parse the orphan and non-orphan spending the best as we can. And then the question is, how do we, if we want, so, you know, if we sort, you know, I sorted by gross spend or net spend total, and then I also sorted by spending per enrollee, and then that really surfaces many of these cancer agents, as well as a few like very rare diseases that we probably don't want to look at, but as just a way to kind of equalize our assessment of drugs that probably have large health system effects, and then ones that potentially have individual effects on patient affordability is, you know, one approach that I took. And how we balance those two things, I'm, you know, whatever board members want to do, I'm open to that. If we do half and half, or mostly on the patient side and a few on the health system side, I'm fine with whatever the board decides.
And as board members kind of contemplate options, another benefit of having the dashboard is that it creates that visualization to kind of look at the drugs from a lens of if not only like the total annual spend. So again, Skyrizi here. This bubble here indicates the WAC price at the end of December. So here for Skyrizi, the WAC price was 21,000, a little over 21,000. And I believe that is the per unit costs. Correct me if that's wrong. And the same with, you know, the Stelara has a pretty significant WAC price at the end of 2024.
Yeah, that's correct. It's the unit WAC.
Okay.
Board member Coder, yeah.
Can you please remind me, was that the average of NDCs or the most utilized NDC?
So this is based off of the most utilized NDC.
Okay. Thank you.
Thank you for that question. So again, apologies for how slow my computer is. This graph represents the total annual net of rebate spend with the number of enrollees on the top, and then the bottom is that total spend to the total annual per enrollee. And so again, you're looking at the total number of enrollees, or the and then, oops, the spend per enrollee.
Yeah, this figure is nice. On both figures, it has the net spending, and then the top line is number of enrollees, and the bottom line is the spend per enrollee. So you can get a sense of, you know, the health system effect in terms of just the bars, and then the potential impact on patients individually by nets or spend per enrollee. You know, you see obviously Keytruda has got high system probably effects, and also maybe a burden for patients if they have a high out-of-pocket cost associated with list price or whatever.
Yeah, in reflection that it is lower to the system. I am so sorry, my computer, I might have to go off camera because it seems to be when I have to share Power BI. Right, I'm still here, but I don't have such a lag. I need to turn my camera off.
Okay. This is Board Member Kennedy. I have a quick question. Since I'm showing sepia in my picture, my hand doesn't show up very well. But should we even be looking at Keytruda? Because it's listed as an anti-neoplastic, and I thought that we had decided that oncology drugs were exempt.
My understanding is that was only the antivirals, the toxoids, and the vaccines
Okay.
were the primary therapeutic class exclusions. I don't have any notes that class.
I don't think we I can't recall specifically putting them off limits.
Yeah, it may have been a consideration, but I don't think it was agreed upon absolute removal that as strongly as it was for the antivirals and the vaccines.
Okay, thank you.
Yeah, no, I appreciate the clarification.
And I'm pretty sure Keytruda made the Medicare list as well, or one of their lists, so.
Yeah, so there's a lot of meaningful information in this one. And then Dan, I believe you had mentioned kind of rebate per enrollee. And again, this kind of shows what that.
Yeah, net spend per enrollee, obviously. So some of these are clearly have sole orphan drugs, hemophilia and things like that, CF. But there's a huge, you know, these yellow bars are primarily oncology.
Yeah, so the different colors represent the different therapeutic classes. So all the yellow ones are the anaplastic one.
There may be some, oh, I see there's, yeah, anti-cancer drugs, and then there's a little bit of a lag between the next one, Ocrevus, is for multiple sclerosis.
Yeah, it's just a little bit off. Yeah, so again, kind of using the dashboard and looking at the drugs from different perspectives and cost impacts to the system. And one of the things about the carrier reported data is that the patient out-of-pocket cost isn't provided. That is the information that we collect through the data call. You will see patient out-of-pocket cost for the APAC or the insulin information because we rely on the APAC information, and it can be pulled from there. But until we get to that subset list and get the additional information on the selected drugs from the carriers, the out-of-pocket costs for the drugs are not available at this time. But this kind of at least gives you an understanding about what the potential impact would be to a patient. Is there any other discussions the board wanted to lean into, or any drill down concepts to consider before next month's discussion? We also want to make sure we have enough time to discuss insulin products. And so just be mindful of time.
I mean, so for the drugs, just so we can kind of have some momentum going into next month when we have to finalize, you know, I don't, you know, there are multiple ways to do this. Like, one way would be to like select maybe 6 drugs that are high spend in total, and then maybe 6 drugs that are high spend per enrollee, and then use that as a preliminary, you know, kind of consider that as a preliminary list. We could like then review. That would give us some time to, you know, some of these drugs have a mix of, you know, orphan, non-orphan indications, and maybe there's some that it might be, I don't want to shy away from that, but maybe there's just some that's too onerous to do the affordability reviews on. But I guess maybe we could just, as homework from this month to next month, kind of board members could think about that in terms of, you know, if we were to like make a list personally, like based on kind of at least those 2 lenses, how would you do 9 and 3, or 6 if we're going to select 12, 6 and 6, or some other breakdown? Board member Lehman.
Yeah, I think I'm great with that plan, Dan. Or Courtney, are you able to share out the filters that you currently have? I know I've been following in the spreadsheet to make the same filters so my numbers are matching, but could you just send out the filters that we just put into place so that we could all kind of start from the same baseline?
Yes, absolutely. I can do that.
And then do you think, this question is for Courtney, do you think it should be homework like, hey, in the next 2 weeks, we should get back to you so that it's not kind of figuring it out on the fly in the meeting? Or how would it work best for staff to get this feedback and kind of make things more efficient for you guys?
Yeah, if you have any concepts that kind of lead to 12, I think hearing from each board member within the next couple of weeks can help staff set up a meaningful conversation and kind of already have the stuff in place so that we get to the conversation for the selection next month, we have a pretty solid direction. So yeah, I appreciate the question. And again, if board members can take that as a homework assignment to submit their, you know, their drill down. And then also, if you don't by chance get to, you know, a specific number, provide what your drill down methodology is. So not just the drug, but really what your methodology, in case, you know, a drug is being removed through like the different removal process. And so if you're doing like different drill down structures, if something else stays on when something else goes off. So, you know, however many you feel is relevant to submit, just please include that, whatever your methodology is to it. And then we can kind of have that displayed in some way by next month.
And the last thing I wanted to say, Dr. Hartung, is just, I follow and track with you. I just have a little worry inside about how we're going to address the orphan drug issue. And so like if my 6 are all orphan drugs, I mean, if say I have 2 groups of 6 and all 6 in the one group are orphan drugs, and then we get into the review and it's like impossible to parse out what's the orphan drug indication versus what's not the orphan drug indication, that's sort of going to exclude those and I could end up with 0 on my list. You know what I mean? So I worry about that piece.
Right. I guess I'm wondering in the affordability review process, I know Courtney, you have mentioned in prior meetings ability to like call out based on age, for instance, would you be if some of these have a pediatric indications that are orphan. But I'm wondering about our capacity to use APAC to actually identify diagnostic codes. That would be more, if we can say these are the diagnostic codes that are orphan indications, and then link that to the pharmacy claims and say we've, to the best of our ability, the best of the data that we have, we've identified the patients who have an orphan indication, an approved orphan indication, and we've pulled them out of the analysis. And so again, to the best of our ability, we are just reflecting the non-orphan utilization.
Yeah, and I'll have to lean into Heather, who deals most readily with APAC, if that is doable. Heather, could you please refresh and let us know what can be pulled from APAC? Can it be a diagnostic code? There you go.
I know Heather was having Zoom problems too, so I'll start, and Heather, please jump in as soon as you're able to get on. One thing, so I think at this stage, we are a little more confident in our ability to separate the APAC data by population groups, and the pediatric versus older people is an obvious one. Parsing the APAC data at the diagnosis code level may be challenging. And I don't think we have done that successfully yet. So, I agree with Board Member Lehman. It could be difficult. I think it's a challenge we should explore, but I don't want to overpromise our ability to do it this year.
Right. I mean, so it would basically, if we have medical claims in the APAC data set, ICD-10 codes, I mean, I know there's no diagnosis codes on pharmacy claims, but if we have medical claims that could be linked back to pharmacy claims, we might be able to, it seems like technically feasible, but again, we don't have bandwidth to do that. Maybe it's not something we want to proceed with. Although I wouldn't mind, I think it's worthwhile exploring. If we don't have confidence in it during the affordability stage, then we could just, we obviously don't have to elevate that drug to be an affordability challenge for its non.
I think where I was going with that, Dan, was just in our homework, maybe we don't come back with only orphan drugs. You know what I mean? Yeah.
Right. No, I agree. No, I totally agree. I think that the challenge will be many of these drugs have one orphan indication. And I was looking as I was looking through these lists in the last couple of days, like I think part of it is they're kind of minor uses, and so because that's just the playbook in industry. So but yeah, like if ones that are just predominantly orphan or exclusively orphan, obviously we don't go there, but we can kind of use our discretion to look at the mix of indications.
And also that's oh, go ahead, Heather. Have you got your audio working now?
I think so. Zoom has really been arguing with me today. And I admit that it was a little difficult to follow the conversation while we were having this argument behind the scenes. But I believe, Sarah, you were saying that we haven't done anything to set, not done anything, but we haven't kept out for diagnosis codes and fully explored it, something we're willing to do. But again, like to reiterate what Sarah said, if I caught that piece of the conversation, was that yes, it's something we can work on, but have not executed at this point in time. I'm not sure if there's more I can add to that, Sarah, because I was missing some of the conversation, but please let me know if I can.
And on the question of the different conditions that a given drug may be used to treat, that's where we really need your expert input as board members for some of these drugs to better understand the ways they are used in clinical care, and whether an orphan designated condition that a drug might treat is a small scale use of that product or a large scale use of that product or something else. So if you can provide us guidance in that area, that's also going to be helpful.
And just, I know we've had some conversations. Last month I presented the information that there is challenges to looking at drugs with an orphan designation condition. And it can continue to be a conversation. However, during your drill down, just be mindful that if the orphan designation has identified, a large number of conditions that might be more challenging for us to have to look at and pull out, versus, the couple that, as Sarah was stating, have more of the, age components to them. And again, kind of being the first time really looking at this from that perspective where, drugs are provided a orphan designation based on the condition, not the whole drug itself, unless that drug itself treats that condition only. But right now, as we continue to look at our data and see what we got between APAC, and then really knowing that if we want to look at a larger number of drugs that include orphan designation, that most of that information be most meaningful coming from carrier reporting. So we'd have to make sure that we can also have time to get that information. So I know it's a little bit more of a newer conversation and concept to look at orphan designations, but also want the board just to know that just because there's a designation associated with a drug, that drug is not completely excluded from looking at it.
I also think that's an argument to kind of limit the number of drugs that we're going to be looking at this year, because the complexity is potentially increased by going down this path, which I think we should, but just to allow staff the capacity to do this work.
And, to your question at the beginning of this conversation, Vice Chair Hartung, about kind of how many meetings to spend on individual drug reviews and the process, we also need to keep in mind that both the annual report and the drug review report findings will be due in December this year. So as a practical matter, we probably need to be writing those reports for that single consolidated report in the October-November timeframe in order to finalize everything by the December meeting. So we'll just have to shorten some of the time that we have for individualized drug discussions, which implies, again, fewer than the 2025 cycle.
Okay, great. That's very helpful. Is there any more discussion about what we should be thinking about for the next meeting from board members? All right, should we talk briefly about the insulin before we adjourn? What we want to do there?
All right. Currently there's 109 NDCs. So insulin information is down to the NDC level. That's how it's pulled out of APAC. And last year the choice was to review just insulin glargine. So looking at guidance from how the board would like to look at insulin products this time.
So I'll just preface this discussion with, I think we made the decision to focus on one drug with all of its biosimilars and competitor agents, just because we were, at least from my perspective, a little unclear what the affordability reviews were going to look like. And so I think there was some consensus that focusing on this one, on Lantus or glargine and all the other glargine products would be helpful to understanding the market dynamics of that specific, it's very heavily used therapy. I guess I'm open, I think we're going to be open to different approaches, looking at a specific category. I think now that we know, or now that I know that we're going to be requesting information about therapeutic alternatives. If we go to a specific category, I'm less tied in and less think picking one specific drug is the way to go. We could go to a category of fast acting. I'm a little bit less conversant on the insulin products than other board members are, but so thoughts from the board? Board member Lehman.
Could we use the same filters that we used before and kind of picked I don't know if, they seem relevant, the things that we used with the drugs themselves in terms of the out-of-pocket cost and the overall spend, and picking a top 3 in each category or something to be reviewed. I know that's not specific to one type of insulin necessarily, but those would be the biggest spends. And it would make it kind of a consistent process between the, non-insulin products and the insulin products.
That makes sense to me. Other thoughts? So what of our top spend in terms of it's probably glargine.
Yeah.
Or
get there.
I would just add that I agree with Chris that I agree that we should have a standardized approach using as many same filters as possible.
Lantus Solstar is on the top. I'm trying to get the drill down to be on the same page. So forgive me as I play with these columns for a minute. All right, so if we're looking, Chris, based off of your suggestion, total overall spend, Lantus Solstar is at the top. Well, pretty much the same drugs that were reviewed during last year's information if we go by total payer.
Board member Coder.
Yeah.
I took a slightly different approach for the insulins because the spend is going to be, Lantus Solstar is one of the most utilized insulins. And so for the insulins, looked at the spend per enrollee. And there are a few that rise to the top if you cut the data that way.
We also have out-of-pocket costs in this data source too, so.
Mhm. All right, that's out-of-pocket costs. So looking at this, we have a fuzzy as far as the pay per enrollee, and then the total enrollee out-of-pocket cost. So you look
It's
at,
yeah, we have three enrollees and one enrollee. I mean, it's very few.
Mhm.
Granted, oh, that's across, this is APAC, so it's,
Yeah, and you're down to the NDC number, so it's even more granular, so.
yeah,
if you're-
yeah, go ahead, Board Member Coder.
Yeah, because there's so little utilization of the inhaled insulin, I was leaning towards looking at U500, which has been around for quite some time, but still has significant costs.
Yeah, I'm having a little bit of a post-traumatic response because I think we reviewed that. We were in the first cycle that we aborted. I think that was on the list, but I mean, I think we by all means look at it again. But I remember reviewing some packet that had U500.
Yeah.
But yeah, that makes sense to me.
The apologies as I try to get this. Okay, so it does come up in the top 3 for payer paid per enrollee. And it has a higher number of enrollees paying for it. So it is a consideration. Does the board want to consider removing any total enrollees, like if it's below 100? That's kind of what I believe the cutoff was last year.
Go ahead, Board Member Hoagland.
Yeah, I think that was a very reasonable cutoff that I think we should continue to use as a way of just helping us drill down.
And I probably have to turn to the spreadsheet to do that. I don't think I can just remove those numbers.
But maybe we can just like mentally remove
yeah.
them.
Yeah. So if we look at, again, looking at either per enrollee, your next one would be another U500, which was in alignment with what was selected in that first review cycle. So we had the U500 and the U500 concentrate. The next would be the Humalog QuickPen.
So process question, if we had, let's say we just selected that, the first U500 and we did the carrier call, data call, we would do it for that specific NDC plus all potential therapeutic alternatives. Is that our process? Just so we can
It can
look.
be.
Okay.
I don't know if, so these don't have any, it shows that it doesn't have any alternatives to it.
Yeah, well, I guess I was thinking more along the lines of maybe other like long acting and things like
I mean,
that.
short acting, because this is a short.
Or short, well, yeah, if we choose more than one
Yeah.
insulin product. Because that's, I guess, I think that's what we wanted to avoid the first iteration on the glargine discussion is, and it was unclear to me before we did this all that we would be pulling in, therapeutic alternatives. 'Cause when we go back to the drugs, we had all the different therapeutic alternatives and their respective, expenditures across the payer groups and things like that. So, and I think going into this, I think the thought was like we would pull all the glargine products just so we'd have them all, but maybe our process entails that we will just get all of them in a data call. I guess that wasn't clear to me before we started that process.
Any other suggestions? Oh, yes.
Yeah, it's not a suggestion, Courtney. I just want to clarify something that Dan said, because I don't think you intend to put all the therapeutic alternatives in the data call, right? I mean, there may be some information in the packet about therapeutic alternatives, but it's not going to be, I mean, you're not going to get all the NDCs of therapeutic alternatives and include them in the data call. Is that what you were asking, Dan?
Yeah, that's what I was asking. So we have
I don't think they intend to do that, but I mean, Courtney would
No.
have to clarify that. I just want to make sure that you hear from them that that's not what they're thinking of doing.
No, not, so when we collect therapeutic alternatives, it's for that drug, the selected drug. And the therapeutic alternatives that were primarily looked at were within the prescription drugs side. The insulin, we didn't really get any alternatives because they were all glargines. They were already, they're equivalents to each other. So that methodology really wouldn't pull over. And we've already identified, so if this was the one that was going to be looked at, it doesn't have any therapeutic alternatives. You could look at maybe the concentrate, but then you still have no therapeutic alternatives. However, if you looked at rapid acting insulin, there's 6. And so you'd see those 6 in the comparison for those alternatives. So thank you for clarifying that, Chris, because we only pulled the
I'm still
therapeutic
not sure.
alternatives.
I'm still not sure. I'm quite sure. So let's use that one as a 6, or that I quite understand. So let's use this one right here that has 6 therapeutic alternatives. So when we looked at the packet for this item, we would see all of the expense data for those other 6 alternatives in the packet, or we would just see them listed as potential therapeutic alternatives.
Well, it would be the same as what we did with the other, where it's a therapeutic alternative that's aligned with the insulin product. So it's already identified 6. So these 6 would be pulled for the cost impact within the system.
Okay, I think that's what Dan is asking. So that's pretty clear. So we will have that information in the packet then.
Yes, that would be collected in the data call. Like if there's 6 therapeutic alternatives, those would be, but I'm just, pointing out that there's no identified therapeutic alternatives for these high priced U500s. So I don't know where the comparison would come unless it's against each other.
Yeah, I don't think he was talking about like U500 when he was asking the question. I think it was a bigger like a question about different drugs. Is that right, Dan?
Yeah, like if we did U500, it's a short acting, and I'm definitely not an expert on insulin products, but I think the board can do what we want to do in terms of like having the data. So if we're really interested in U500, but we want to know other things that are comparable that could be used potentially like U500, do we want to have that information pulled in so we have some sort of better context in terms of like the data call is, I think, just a general question. And I don't know if that's like like regular insulin, if we just want to have a comparison with that, or
Yeah, or since, this one's a short acting, you can do another short acting, even though it only shows one alternative. Which is, so like these Humulin, I think, is the therapeutic alternative to Novolin and vice versa.
Right. And like Humulin and Novolin, they're definitely not in this equivalent kind of
Mhm.
than to U500, but it might provide contextual information for allowing the board to assess affordability of U500, knowing something about other kind of regular insulins, because it's just a concentrated version of regular insulin.
Well, this one is the
Yeah.
concentrated.
So I guess that's the process question is like, when we do the data call, do we want to make sure that we have comparable agents to pull along with the agent that we're specifically focused on? Or set of NDCs or whatever, however we want to frame it.
And that would be helpful for staff to know, so we know how to set up the data call information. Because it's not a, it's not a structuralized part of the process. It is for the preliminary or for the prescription drugs, because that's how the board has set it up and found it to be most meaningful for your reviews, is for those therapeutic alternatives. But it wasn't a discussion to have within the insulin.
Well, how about this? We're kind of running up to our time limit here, and just want to be sensitive to that maybe that the board follows a similar exercise over till the next meeting, and kind of board members individually review this insulin data set and kind of maybe select 1 to 3 insulins as chairman or as board member Lehman suggested, and then we kind of come back, settle on some consensus, and then the rest of it is just as staff instructions for how to like do the data call affordability stuff based on that decision.
Yes, that'd be very meaningful. And then again, if board members do insulin, please send those products with your drill down to staff so we can get that set up. And there's no specific criteria for the insulin products except for just not selecting less than 100. So I'll send an email out with what the parameters are for the preliminary prescription drugs are, and then what the insulin, with that one requirement for insulin. But thank you very much, board, for your conversation and guidance today. We'll get this all set up, and I will have, if I have any questions, I'll be reaching out to you. Thank you.
Board member Coder, did you have a question or a comment?
Yeah, it was just a process question when the board staff would need this information by in order to prepare the materials for the next meeting.
I'll include that into my email. I'll hopefully be able to send that out later today or first thing tomorrow, but I'll have a better guidance once I can get a rest period from all this, get my brain stop feeling like soupy mashed potatoes.
And I could also speak to that a little bit, Michelle. Not a fixed deadline, but obviously we post the meeting materials the week before the meeting, and we need at least a week before that to get them drafted. So it's most helpful to us if you can get us any feedback in the next week or two. Then we just have more time to incorporate it. And I would also please ask all of the board members, as you are reviewing the dashboard and the Excel spreadsheet, which have the same data for the preliminary list, please reach out at any time if you have any questions about the data in the list, about how to navigate it. I don't want your work to be slowed down by the tools. And so if there's anything we can do as staff to help you use these tools better and answer any questions, please reach out right away, and we're happy to find some time and talk or answer questions by email or both, so that you are able to use the information that we have published. So just want to reiterate that.
Great. Thank you. And thanks for, again, the tools I think are, I've been finding them more and more helpful. So I appreciate staff and kind of refining them. I think that they've turned into something really a great resource for us and the process and the board. So, okay, the final pieces are, I just want to announce that the next board meeting is March 18th at 8 a.m. And if there is no further business before the board. Oh,
Could I ask a question, Chair
Yeah.
Hartung? It has to do with a public comment that was made earlier in the meeting. I know we don't deliberate on public comments or things like that, but it is something that I hadn't noticed until now. The flyers, Sarah, for the listening sessions or the engagements with the community, they do say learn why drug costs are so high. I mean, should we not, and I don't know if we can, but is there a way to make it seem like it's more be a part of I know it says right underneath it, help us identify solutions, but I'd be interested in hearing other thoughts about that flyer, which I read it before. I thought it looked great, but until the comment that was made, I hadn't noticed that. So I just want to put that out there.
So really, the flyer reflects our best efforts on what will attract people to come. Welcome other suggestions on additional advertising we can do. I am very much planning for those sessions. You know, we want to include a brief presentation as part of it because I think there's also a lot of people don't know what the PDAB does. So certainly want to take a little bit of the time during those sessions to share. And you know, I'm really planning to strongly emphasize, we're here to listen to you. Thank you for coming. So as a practical matter, can't really change the flyer at this point since we've already sent it to a lot of folks. But please share ideas on additional ways we can communicate that message.
Yeah, and so it's not necessarily then changing the flyer, but I do think we as a board echo exactly what you just described, that it's about engaging with the community members and hearing their stories and getting their feedback and thoughts on and input on how they're struggling and any potential solutions so that we can learn more and be really informed by everyone in the state as we go through and do this work. So I just wanted to emphasize that to the person who made the comment, like it is the goal to get, you know, feedback from community and stakeholders throughout the state.
Yes, absolutely. And we will also be sending out, we're essentially going to manage it as a sign-up sheet to identify which sessions various board members may be able to attend. Of course, I can't invite you all to attend the same session because then we create a de facto public meeting. But I'm coordinating with Melissa and with all of you to identify who can come to which sessions. And, you know, we'll be consolidating everything we hear in a final report back to the board as well. Please let us know if there's any additional ideas that come up as we're getting closer to our April kickoff for these public sessions, and we'll keep working to make them as open and welcoming to patients and consumers as possible. Thanks for
yeah, thank you, Board Member Lehman. I endorse that concept 100%. So I think that's it. No other comments. There being no further business before the board. All in favor of adjourning the board meeting, say yes.
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 Any opposed?
Yes.
All right. The meeting is adjourned at 11:57 a.m. So thank you all.